Indian College of Anesthesiologists welcome you all to our Wednesday evening webinar. Believe you are all keeping very well and the webinars are progressing. This is our 94th webinar in succession. Soon we will be hitting our 100th webinar in next month, and which we are going to celebrate for a different program. Yeah, Tanisha started the program already. Yeah. And today's webinar is a much awaited area, slightly complex area, which usually we have not discussed till now, because this particular area goes out to a tertiary care hospital. It's mostly on post-transplant patients as well as post-ischemic patients. If they are struggling with some sort of problem, how they should be effectively repaired, anesthetized, and put back as normal productive citizens of us. And this particular topic is going to be dealt in detail by Dr. Sandeep Sahu, Professor of STPG in Lucknow, and his team from different places. Well, people who are participating with him are Hemant from Chandigarh, Kiran from Chandigarh, Gaurav from Delhi, and ICA Pandey also from Delhi. And I request Sahu to take over the webinar and start the proceedings. And we will interfere later in the end. And here to you, Sahu.
Thank you, sir. Thank you so much for giving us opportunity to have this webinar on two important topics on behalf of ICA. And we thanks being the president of ICA to you and all the office bearer to have given us opportunity and believing in us. This webinar, we have put two important topics, because as the now in India, the cases of post-transplant are increasing. Although it is focused, transplant is happening only in few limited centers, but patients are moving from all over India to this center, and after transplant from this center to all part of India. And most of the time they have some emergency or some non-transplant problems. For that, they come to us in emergency, in OTs, in ICU, and how to know about these patients and how to treat them. For this, we have in today's discussion. First, I would like to introduce the chairpersons. The first chairperson, Professor C.K. Pandey, sir. Please have the CV of Professor C.K. Pandey, sir. Professor Chandrakant Pandey, sir, who has been professor at Department of Anesthesia, SDPGIMS. And from here, he moved to ILBS, the Institute of Liver and Biliary Sciences, New Delhi, Vasant Kunj, where he headed the department. Also, he being the Dean of Academics and established Department of Anesthesia and Organ Transplant Anesthesia in ILBS. And I will say and congratulate him to start first DM course in Organ Transplant Anesthesia and Critical Care at ILBS. From there, sir moved to back to Lucknow to RML Institute of Medical Sciences as a professor in critical care medicine. And he also being the chief medical superintendent here in the RML Institute of Medical Sciences, Lucknow. And currently he is the director of anesthesia services at Medanta, Lucknow. So I will request sir to please unmute yourself and
okay.
Another chairperson for the yes sir. The another chairperson I would like to introduce is Professor Hemant Bhagat. Professor Hemant Bhagat has done his DM in anesthesia, who started first batch, initial batches from AIMS, New Delhi, and then he is selected as a faculty at PGI Chandigarh, critical care at PGIMR Chandigarh, and presently he is working there as professor. Please unmute yourself, Hemant Bhagat sir, and also open your video, please. So over to both the chairperson. I request Pandey sir to first introduce the first speaker, and please take over as for whole the session.
Okay, thank you, Dr. Sahu, for inviting me as a chairperson for this session. And my sincere thanks to Indian College of Anesthesiologists who has chosen me as a chairperson for this important topic. What I'm going to deal at, either the speakers are going to deal in next 45 minutes, that is the transplanted patients who are supposed to go for the non-transplant surgery. And because these are the new spectrum of the patients. And these patients, once they are having the graft, important is that they are coming for the surgery. Probably they are on many drugs, which are sometimes they are immunocompromised, they are having some source of infection, and there are many issues. And sometimes they are landing up in the emergency procedure when you don't have the time. And if they are coming for the elective procedures, then definitely you have some time for the preparation. So all these to be dealt by the Dr. Gaurav Sindwani, who is Associate Professor at Institute of Liver and Biliary Sciences, and he is a dynamic person. So please, without over and to speak on this topic.
We are seeing your slides. Your slide is.
Am I audible, sir?
Yes. Now you are audible.
You can, yeah.
Thank you, sir. Thank you for the introduction. First of all, I would like to take this opportunity to thank Dr. Radhakrishnan, Dr. Jayashree Sood, Dr. Baljit Singh, Dr. Sandeep Sahu, and the whole ICA team for giving me this opportunity to speak on this topic. So today I'll be speaking on the anesthesia management of post-transplant patients coming for the non-transplant surgery. So my today's talk will cover what all organs can be transplanted from one person to the other person, a brief overview about the number of transplants occurring in India and the worldwide, perioperative anesthesia concerns of post-transplant patients coming for the non-transplant surgeries. Due to the time limitation, I'll be focusing on the liver and kidney transplant recipients coming for the non-transplant surgery and special cases such as pregnancy in the solid organ transplant patient. And finally, the conclusion. So these are the common organs which can be transplanted, such as kidney, heart, lung, liver, intestine, and the pancreas. However, there are many other organs and tissue which can be transplanted, such as bone marrow, skin, and the cornea. UNOS, that is United Network of Organ Sharing, have reported 33,000 cadaveric transplants in 2020 in the United States, while this number increased to 40,000 cadaveric transplants in 2021 in the United States. As you can see here clearly that the number of kidney, liver, heart, and lung transplants are on the rise since 1988 in the United States. India roughly requires around 2 lakh kidney transplants, 50,000 heart transplants, and 50,000 liver transplants annually. But actually, India is doing only 8,000 kidney transplants and 2,000 liver transplants with very few heart and lung transplants. This is a recently published data on the current status of the disease donor organ transplantation in India. And based on this data, India has so far performed 40,000 kidney transplants, 10,000 liver transplants, 900 heart transplants, 500 lung transplants, And as of now, India have performed only 8 small bowel transplants. So with the improvement in the surgical techniques and the improved immunosuppression protocols, the long-term survival after organ transplantation have improved significantly. So this is a recently published data on the long-term survival after liver transplantation in 4,000 consecutive patients. And they found that the long-term survival after 18 years of liver transplantation was 48%, and it was significantly better in children and in female recipients. This is another recently published study on the long-term outcome after the kidney transplant, and they found that the median survival of 8.2 years in 1995 have significantly improved to 19.2 years of survival in the year of 2017. So as you can see here clearly that the 5-year survival after the heart, lung, liver, and the kidney transplant have significantly improved. So it is not uncommon for the anesthesiologist to face these patients coming for the non-transplant surgeries. The common surgeries for which these patients can come are the ultrasound-guided biopsy, CT and MRI, bronchoscopies, endoscopy biopsies, endoscopy for the upper GI bleeding, complications for the immediate transplant complications such as thrombosis, hemorrhage, and the biliary complications. Traumatic fracture and the avascular necrosis of the hip is also common in this patient. So they can present for the fracture repair or for the hip replacement surgeries. So what are the challenges faced by the anesthesiologist in the perioperative period while managing these patients for the non-transplant surgeries? First thing is that they can have an altered physiology due to the transplanted organ. They are on some kind of immunosuppressive therapy, and these drugs interact with our anesthetic agents. And there is also an increased risk of infection and organ rejection in the perioperative period. So a brief overview about the immunosuppressive drug. Most of the post-transplant patients, they are on some kind of immunosuppressive regimen. The commonly used immunosuppressive drug, they have a narrow therapeutic range and variable blood levels between the individuals. So it is important for the anesthetist to know how this drug interacts with our anesthetic agents. Induction agents, they are given before the implantation of the organ, such as ATG and the basiliximab. While the maintenance immunosuppression, they are given with calcineurin inhibitors, such as cyclosporine, steroids, and the antimetabolites. These are the commonly used immunosuppression drugs, which are commonly used. Nowadays, trend is to use decreased dose of corticosteroid or even corticosteroid-free protocols for these patients. Calcineurin inhibitors, they are still used commonly in these patients. However, the trend is to use tacrolimus over the cyclosporine. Similarly, in the antimetabolites, mycophenolate mofetil is preferred over the azathioprine. Polyclonal antibodies such as ATG and anti-interleukin-2 receptor antibodies such as basiliximab, they are used as an induction agent. Now, the side effects of the immunosuppressants. Cyclosporine, they can cause dose-dependent nephrotoxicity, which is reversible also. So if a patient has an increased creatinine level, their cyclosporine dose should be decreased. It can cause hypertension by the renal artery vasospasm, which can be treated with the calcium channel blocker and the AC inhibitors. Tacrolimus is 100 times more potent than the cyclosporine, and it causes less hypertension when compared to cyclosporine. And it does not cause gingival hyperplasia and the hirsutism. However, the incidence of nephrotoxicity is much higher when compared to cyclosporine. And very rarely, it can also cause the hypertrophic obstructive cardiomyopathy. Now, coming to the antimetabolites, mycophenolate mofetil causes less bone marrow suppression when compared to the azathioprine, and the fever anaphylaxis is more common with the ATG. Now, coming to the immunosuppressant drug interactions, they can be divided into the anesthesia drug effect on the immunosuppressant or the effect of the immunosuppressive drug on the anesthetic drugs. So about the interaction of the immunosuppressive drug, immunosuppression, they can increase the level of benzodiazepine, opioid, and the muscle relaxant. So their dose should be decreased when they are given in these patients. Isoflurane, they can increase the level of cyclosporine A. Neostigmine should be used with caution in the post-heart transplant patients, while thiopentone, propofol, etomidate, and local anesthetic does not have any interaction with the immunosuppressive agents. In this study, they have found that even a single dose of cyclosporine can prolong the effect of pentobarbital hypnosis and fentanyl analgesia in mice, but they could not find the mechanism how it causes the prolongation of these effects. So these are the other most commonly used non-anesthetic drugs which can increase the level of immunosuppression, such as antibiotics, which includes erythromycin, norfloxacin, and the levofloxacin, antimicrobials such as rifampicin, antimalarial, antiretroviral, antiarrhythmic such as amiodarone and the verapamil, and the commonly used analgesics such as NSAID, they can also increase the level of these immunosuppression drugs. Now coming to the anesthesia management of post-transplant patient coming for the non-transplant surgery, it includes the proper pre-operative assessment of the transplant recipient, general anesthetic consideration in these patients, specific anesthetic consideration depending on the type of organ they have received, and the consideration for the special cases such as pregnancy in solid organ transplant. So starting with the pre-operative assessment of the transplant recipients, it includes the pre-operative evaluation of the graft function. And it is also important to look for any signs of graft rejection. Presence of infection should also be ruled out, and the function of other organs should also be checked. Rule out the side effect of the immunosuppressive drug and consider stress ulcer prophylaxis with the proton pump inhibitors when these patients are coming for the non-transplant surgery. And it is also very important to consider thromboembolism prophylaxis in these patients. So I'll be discussing all these points further. Starting with the graft function, graft rejection, it can occur anytime after the organ transplantation. However, the chances are maximum in the first year. Rejection is of two types, antibody-mediated or the T-cell mediated. Antibody-mediated rejection usually results in the acute rejection, while the T-cell mediated rejection usually results in the chronic rejection. The definitive diagnosis of rejection is by the histopathology. And any degree of rejection, it should be treated urgently before the surgery. So here they have tried to find out the incidence of chronic rejection, and they found that the incidence of chronic rejection after liver transplantation have significantly improved from 25% to just 5%, while for the other organ, it is still around 25 to 30% after 5 years of organ transplantation. Now, this is the rejection activity index for the diagnosis of acute cellular rejection. Based on the portal inflammation and the bile duct inflammation damage, the severity of acute cellular rejection can be judged. Similarly, to differentiate early chronic rejection from the late chronic rejection, small bile ducts, hepatic arteriole, and hepatic veneole involvement should be seen. The differential diagnosis of the rejection includes hepatic artery thrombosis, biliary issues, portal vein thrombosis, post-transplant infections such as cytomegalovirus and the atypical viral infection. Sometimes it is very difficult to differentiate infections from the rejections in the immediate post-transplant period. And the other type of rejection such as acute cellular rejection, chronic rejection, antibody-mediated, and the plasma cell-rich rejections. Now the acute rejection, they usually respond well to the steroid and the escalation of the immunosuppression. If it is a steroid-resistant acute cellular rejection, it should be treated with ATG, tacrolimus, sirolimus, or MMF. While the chronic rejection, they are difficult to treat, but the treatment is also the same. They are also treated with the escalation of the immunosuppression and with the use of sirolimus. So now coming to the infections after the organ transplantation, infections, they occur in the timely manner after the organ transplantation. This is a timeline of the infections after the transplantation. You can see here that within 1 month, surgical site infection, bacterial infection, HSV and Candida are more common, while in 1 to 6 months, opportunistic infection becomes more common, such as Pneumocystis carinii and the CMV. And after 6 months, community-acquired infections becomes more common. This is the epidemiology of the invasive fungal infection in the solid organ transplantation. As it is clear from this chart, Candida is the most common invasive fungal infection in kidney, liver, pancreas, heart, and small bowel transplant, while invasive aspergillosis is the most common infection in the post-lung transplant patients. So this is the prevalence cohort study where they evaluated the solid organ transplant recipients requiring the hospitalization during 2007 to 2011, and they found that the infectious complications were found in 603 of 1440 readmissions. And they found that more than 85% of these infections occurs after the 6 months of the transplantation. And the most common infection was the respiratory infection. And they found that the 53% of these patients, they presented without fever, and 45% had no pathogen isolated. And out of the 55% where the pathogen was isolated, 27% had multi-drug resistant pathogen. So this is another study where they tried to find the timeline of infectious disease in the first year after solid organ transplantation. And they found that among 3,541 solid organ transplant recipients, almost 1,500 patients suffered 3,500 infections. And they found that the bacterial infections were the most common in the first year after the organ transplantation. And among the bacterial infection, Enterobacteriaceae was the most common organism. So this is another interesting article where they actually found that compared to known solid organ transplant patient, kidney, liver, and co-transplant recipients, they demonstrated the lower mortality. And there was no association for heart and lung transplant with the higher mortality. So this is a table where they suggested the prevention and the treatment regimen for the various infections after the liver transplantation. They suggested to use cephalosporin for the bacterial infection, acyclovir for the herpes simplex virus infection, valganciclovir for the CMV infection, fluconazole, echinocandin, or amphobi for the candida infection. Now coming to the antibiotic prophylaxis. The antibiotic prophylaxis, when these patients come to us for the non-transplant surgery, it should be given in a standard manner, and there is no need to cover for the atypical organism or the opportunistic infection organisms. So the next thing is the post-transplant diabetes mellitus. So these patients can very commonly, they can have a diabetes mellitus in the post-transplant period. So diabetes in the post-transplant period can be termed as new onset diabetes mellitus, transplant-associated hyperglycemia, steroid diabetes, new onset diabetes after transplantation. However, international expert panel, they have recommended to use the term post-transplant diabetes mellitus for diabetes after organ transplantation. It is diagnosed after 45 days of organ transplantation when the random blood glucose level is more than 200, or fasting blood glucose level is more than 126, or the 2-hour plasma glucose on the oral glucose tolerance test is more than 200, or if the HbA1c level is more than 6.5%. Mind it, normal HbA1c level does not rule out the diabetes mellitus in the post-transplant patients because of the presence of post-transplant anemia and the dynamic function of the kidney. Hyperglycemia within the first 45 days after transplantation should be treated with insulin, or it can also be treated with OHS. And after 45 days, it should be screened with oral glucose tolerance test, or by fasting or random glucose level, or with the HbA1c level. Out of all these tests, OGTT is supposed to be the best test for screening these patients. The incidence of post-transplant diabetes mellitus after kidney and liver transplant is roughly around 20 to 25%, while after heart and lung transplant, it is around 30 to 40%. Now coming to the management of diabetes after organ transplantation, their screening, if the screening HbA1c is in the pre-diabetic range, patient should be counseled for the dietary and the lifestyle modification, and HbA1c should be monitored every 3 months. And if it is a newly diagnosed case of post-transplant diabetes mellitus, along with dietary modification and lifestyle modification of immunosuppression is also recommended. They recommend to taper the dose of prednisolone to 5 mg per daily in the maintenance dose. However, routine corticosteroid withdrawal is not recommended, and whenever possible, they recommend to shift from tacrolimus to cyclosporin if the patient has a low immunological risk patient. Now coming to the hypertension after solid organ transplantation, it is also common after transplantation. And the common causes for the hypertension after solid organ transplantation are the calcineurin inhibitors such as tacrolimus or the cyclosporin, use of steroids, kidney dysfunction, which is quite common after the organ transplantation, expansion of the intravascular volume, and the improvement in the systemic vascular resistance can also cause hypertension. And another important reason after the kidney transplantation for the hypertension could be the presence of the native kidney. So if a patient of post-kidney transplant had a refractory hypertension which is not responding to the drugs, native kidney nephrectomy should be considered in these patients. And a caution about the use of calcium channel blockers in these patients because they can increase the level of calcineurin inhibitors. Now coming to the anemia after the solid organ transplantation, it is defined as the 2 standard deviation below the population mean of 11.5 gram per deciliter in women and less than 13.5 gram per deciliter in men. Its prevalence is around 25 to 40%. It can be early post-transplant anemia or it can be late post-transplant anemia. The causes for early post-transplant anemia are the blood loss, infection, marginal graft, or the iron deficiency. And for the late post-transplant anemia, most of the time it is the decline in the graft function which causes the late post-transplant anemia. However, other uncommon causes could be bleeding ulcer, malabsorption syndrome, or the use of immunosuppressant. This is a study where they tried to find out the factors which were responsible for causing the anemia in the first year after the transplantation. And they found that the lower kidney function, female gender, transferrin saturation below 10%, and proteinuria were associated with moderate to severe anemia after kidney transplantation within 1 year. This is another article where they recommended to keep a hemoglobin of 12.5 to 13 gram per deciliter in the post-transplant patients. And to achieve this target, they have even recommended to use erythropoietin stimulating agent and iron if it's indicated. Now, the venous thromboembolism after solid organ transplantation. The incidence of venous thromboembolism after various transplantation is roughly around 2 to 30%, and it is maximum after the heart transplantation. Hypercoagulability after organ transplantation can persist indefinitely, but the chances are maximum in the first 6 months. And the causes for the hypercoagulability after kidney recipient after the kidney transplantation is the impaired fibrinolysis and protein C activation, while the hypercoagulability after liver transplantation can be due to the increased von Willebrand factor activity with decreased activity of the antithrombotic factors. So what are the common factors which can cause the hypercoagulability in the post-transplant period? The first thing is the use of the immunosuppressants such as cyclosporine, azathioprine, tacrolimus, and the sirolimus. They all can cause hypercoagulability in the post-transplant period. Other important cause is the presence of the CMV infection. And the other important cause is the pre-transplant diagnosis, which could be lupus nephropathy, metabolic liver disease, hepatitis C infection, and interstitial pulmonary fibrosis. So they have recommended both. Pharmacological and the mechanical prophylaxis for the treatment of VTE in these patients. Now, coming to the post-transplant lymphoproliferative disorder, the incidence of PTLD in tonsil is less than 2%. However, it is important to diagnose PTLD in this patient because it can cause difficult airway or difficult ventilation. Other preoperative consideration in these patients is the timing of surgery, which is very important. Any surgery in the immediate post-transplant period can have a devastating effect on the transplanted organ. Immunosuppression dose need not to be altered until their route of administration is altered. To maintain the therapeutic blood levels, oral cyclosporine or tacrolimus must be administered within 4 to 7 hours before the surgery. Steroid stress coverage in general is not necessary. However, it is recommended only if the recipient has been recently withdrawn from the steroids. Now, the general anesthesia consideration, monitoring, invasive monitoring in general is not required, but it can be secured on a case-to-case basis. And the aseptic technique is of utmost importance in these patients because they have a very high chances of having perioperative infections. Now, the airway management in this patient, as I have told previously, that the lymphoproliferative disorder of the airway or mediastinum can result in the difficult airway or the difficult ventilation in these patients. Gingival hyperplasia can result in the bleeding from the gums. Delayed gastric emptying can be taken care of by giving prokinetic to these patients. Whenever possible, oral endotracheal intubation should be done over nasal intubation because of the decreased chances of infection. And the hyperventilation should be avoided because they have a low threshold for the seizures, as these patients are on tacrolimus or on cyclosporine. Now, the intraoperative management in general anesthesia is not contraindicated, and any anesthetic agent can be given to these patients provided they have a normal hepatic and the renal function. The use of laryngeal mask is also acceptable. Regional anesthesia is also safe in these patients. Postoperative care, analgesics such as acetaminophen can be used in these patients up to a dose of 3 grams per day. However, non-steroidal anti-inflammatory drugs should be avoided because if they are co-administered with tacrolimus or cyclosporine, the chances of nephrotoxicity increase in these patients. Epidural block, wound infiltration, or peripheral nerve blocks can be given to these patients. Patient can have surgery in the ambulatory surgery center for minor procedure. Now, the specific concerns related to the kidney recipients. Patients of end-stage renal disease can have various cardiovascular abnormalities, and they also have a high incidence of coronary artery disease. So it is important to rule out or to properly evaluate their cardiac status when they are coming us for the non-transplant surgery. Decreased GFR and effective plasma flow can have an altered effect on the drug metabolism, so drug dosage should be adjusted in this patient. Meticulous perioperative fluid management is the key for the successful management of this patient. Now, the specific concerns in the liver transplant recipients. Immediately after the liver transplantation, drug metabolism recovers, while LFT and the synthetic function of the liver takes around 2 to 3 weeks to recover after the liver transplantation, while the resolution of the hyperdynamic circulation or reversal of shunt may take from months to a year to recover after the liver transplantation. This is an interesting case report of a 16-year-old female who had a severe hepatopulmonary syndrome before liver transplantation, and her arterial oxygen tension was around 54.5 millimeter of mercury before the liver transplantation, and it took around 11 months after the liver transplantation for her arterial oxygen tension to become normal. This is another study where they assess the pulmonary hypertension before and after the liver transplantation, and they found that the mean pulmonary artery pressure has significantly improved 3 months after the liver transplantation, and it improved from 37 millimeter of mercury to 27 millimeter of mercury. And they also found that there was significant improvement in the number of patients with TR at the 3 months of the liver transplantation. Now, there are few diseases which can reoccur after the liver transplantation. These are primary sclerosing cholangitis, primary biliary cirrhosis, autoimmune hepatitis, non-alcoholic fatty liver disease, HPV and HCV can also reoccur after liver transplantation. Now, if the surgery is needed in the first few weeks after liver transplantation, blood pressure should be kept in the normal range, and hemoconcentration should be avoided to avoid complications such as hepatic artery thrombosis or the portal vein thrombosis. So their HB target should be decreased to 7 grams per cent. Now, coming to the special cases. Pregnancy after the solid organ transplantation. First live birth after kidney transplant was in 1958, and patients with solid organ transplant, they report their pregnancy to National Transplant Program Register. As of now, around 1,000 kidney recipients and 233 liver recipients have given birth to 1,400 live births. American Society of Organ Transplantation suggested that pregnancy after 1 year of stable graft is safe, and they have defined that stable graft as the graft who had no episode of rejection in the past 1 year, with a stable renal function and with low risk of opportunistic infections. Use of immunosuppressants, they can be used in the perioperative period during the pregnancy, and their teratogenicity potential is also very low. However, there are various factors which can affect the level of these drugs because of the changes in the maternal physiology, increase in the maternal weight, and the altered drug metabolism. So it is very important to monitor their blood levels, and it should be monitored every 4 weekly till 32 weeks, then every 2 weeks till 36 weeks, followed by weekly till 1 month after the delivery. In this cohort study of 1865 women, which included both kidney and the liver transplant recipient, they found that for kidney and liver transplant recipient, normal labor or a normal vaginal delivery was better compared to the cesarean delivery. These are the 2 case reports where they accidentally injured the transplanted organ with the shearing force injury of a kidney transplant graft. So they recommended to use the median laparotomy incision instead of the Fininstein incision in these patients. Finally, to conclude, the increasing number of patients with organ transplant makes it likely that every anesthesiologist will care for patients with a transplanted organ. Local, regional, or general anesthesia can be safely delivered to transplant recipient. It is essential to have an appropriate knowledge of the physiology of the transplanted organ and the presence of associated organ dysfunction. Additional research is the need of an hour to formulate the guidelines for anesthesia in post-transplant patients. Thank you very much for your patience.
Thank you, Dr. Gaurav. You have taken an exhaustive list and all physiological aspect, probably the drug metabolism and all. One interesting case we have encountered recently, that is one of the patient who got uterine transplant for infertility, and she operated for the cesarean section. And this was basically you see that there is a one organ which is transplanted for, and once she conceived, then she has gone for the cesarean. So that is how we are dealing with the patients. And you covered a lot of about the heart, lung, and liver, kidney, and so many things are there. So the important thing is that we have to preserve the grafted organ, number one. That is the main focus, that grafted organ in whichever the condition you have received, that function should not deteriorate. Number two, because of these organ transplant, there is some physiological changes. Because of the drugs, we are keeping those organs in the body. So because of those changes, we have to manage, as you said, that is mellitus, hypertension, and so many things are happening because of the myeloproliferative disorders are happening. So taking into account in holistic view, we have to take the patient into consideration. Things happen wrong only when we are not versed with the subject and physiology of the patient. To another aspect, that if we are having time, like these patients are coming for the elective procedures, then definitely we have time to prepare them. But most of the times, these patients are landing up for the emergency procedure, like perforations. These patients are very prone for the enteric perforations. And sometimes that is a trauma or fractures and so many things. So in that situation, that is an important aspect, that now the anesthesia spectrum is widening, and rather than only knowing the anesthesia drug, we have to know the immunosuppressant and their physiology and pharmacology as well. Hopefully, in over the years, as these things will improve, understanding of the anesthesiology will also improve, and hopefully they will be much better positioned to manage these patients. I hope everyone who is on the panel have heard Dr. Gaurav Sindwani, and he covered nicely most of the things in 45 minutes. And it is I congratulate him for the excellent delivery. Thank you very much.
Thank you, sir. Thank you.
Thank you, Dr. Gaurav, and Chairperson Professor C.K. Pandey, sir. Definitely, the concerns are definitely this patient will not come for routine elective surgeries, but for emergency surgeries, when anybody is getting this type of patient, they should not be worried, because the patient is far away from the center where he was transplanted. But it's always better they know the patient from before transplantation, so that can help us in understanding in toto that type of patient for non-transplant surgery. And as take any patient for non-transplant, hypotension, hypoxia, keeping everything in normal range, like normoxia, normotension, normoglycemia perioperatively is good, because the graft function depend on all this blood supply and all this, even liver or kidney. And a little thing that I know, that TAC level, the immunosuppression that patient is taking, only the steroid and tacrolimus, the TAC level is not done everywhere in periphery, and it takes time. So we should know that only one thing, that if TAC level even is high, the tacrolimus level is high, even more than 10, then it can itself cause organ dysfunction, especially in kidney. So perioperative, if we know this thing, interaction of immunosuppression with the human body, because the immunosuppression is not much interacted with our anesthetic. That's a good thing. So with this, I will like to thank the speaker and chairpersons for their valuable time and their valuable suggestions from their wide experience in this field. Thank you, sir. Thank you so much.
Dr. Sandeep, may I take your permission to come out from this? Basically, we are conducting right now a case of the liver transplantation going on. So I'm required there. So if you permit, I can go there.
Please, sir. Please, sir. We are very thankful. Meanwhile, from your team, you came here as per your commitment, and we are highly obliged, sir.
Thank you.
You may please continue, sir. Transplant, sir. Your transplant is going on Medanta, but still, sir has come on time and conducted the session. And on behalf of ICA, I thank you, sir. So now we are moving for the next session, and for the next session is the chairperson is Professor Hemant Bhagat, sir. I will request him to take over and please introduce our speaker. Thank you, sir.
Yeah, good evening, everybody. The foremost, I would like to thank the Indian College of Anesthesia for organizing this webinar, and especially Professor Radhakrishna. I would like to thank Dr. Sandeep Sahu for giving me this opportunity to chair this session, and it's my pleasure to be here. And as you all know, that as per the WHO the census, ischemic stroke is one of the leading causes of death. In fact, it is the second only cause after the ischemic heart disease as the major cause of death globally. And as far as ischemic stroke is concerned, the anesthesiologists are conspicuous by their presence in all of the critical care areas. And one of the areas where they constantly encounter the patients are the DSA lab for mechanical thrombectomy, or in the operation theater for decompressive craniotomy, or in the neurocritical care centers where you have to manage patients after they have suffered a stroke. And secondly, the chronic patients with chronic stroke who come for either carotid stenting or carotid endarterectomy, or maybe they come for some other surgery following stroke. So today we have one of a very knowledgeable and experienced speaker, Dr. Kiran Jangra, who has a very wide experience of managing the patients of stroke, and she has a good experience of both the clinical research and academic management of this group of patients. Dr. Kiran Jangra is an associate professor of neuroanesthesia at PGIMER Chandigarh. She has widely published and has a lot of awards to her credit. And without taking much time, I would request Dr. Kiran to delve on her topic. Over to you, Kiran.
Thank you so much, sir, for the kind introduction. I would like to thank the entire ICA team, and especially Dr. Sandeep Sahu, to give me the opportunity to be here in this platform. And special thanks to my mentor, Dr. Hemant. Definitely, he guided me at each and every step. So to begin with, first of all, I present greetings from my institute. This is my institute, PGI Chandigarh. So in this webinar, I will be dealing with the stroke overview, followed by anesthetic management of acute ischemic stroke, then anesthetic management of the chronic stroke, followed by a patient who had a previous stroke coming to the other surgeries, and finally concluding my slides. So coming on to the overview of the stroke. So first of all, what is a stroke? Stroke is nothing but it is acute focal injury of the CNS, which is caused by a vascular cause. It may be hemorrhagic, it can be thrombotic. So hemorrhagic consequences can be intracranial hemorrhage or subarachnoid hemorrhage. And the saying thrombotic events is acute ischemic stroke. So today we'll be dealing with the acute ischemic stroke here in this webinar. So the beauty of acute ischemic stroke is whenever there is a occlusion in the artery, it will cause a decreased supply of the area of the brain, which is supplied by that artery. So the problem here is there is a core, which is the infarcted brain. So whenever there is an acute occlusion of the supply to the brain, that area of the brain will start dying, and that neurons are infarcted neurons. It is not the only thing that the primary insult is over, then the disease is settled. The disease is spreading now because that core is going to expand, because the surrounding area of this core is called as a penumbra zone. So the problem with this zone is if we restore the blood within the timeline, then this area can be revived. And if we lose that time, then this cord will keep on expanding and the entire area supplied by the parent artery will get infarcted. So patient will have a huge infarct in the area of the arterial occlusion. So in nutshell, what I will say, the time is brain is a very good mnemonic we all are aware of. So if we lose the time, we are losing the brain. So we have to be very, very quick in detecting the stroke and in managing these stroke patients. So where anesthetics are required in emergency room, maybe for acute stroke revascularization, such as clot retrieval, for the chronic stroke revascularization, especially for the angioplasties in the form of the balloon or the stent placement, or for the carotid and arterectomy, or for the stroke patient who are coming for the non-stroke or the non-neuro surgeries. So what we have to do in the emergency room care, first of all, when we get a patient who is having some acute intracranial injuries and are presenting to us with the neurological deficits, first of all, we have to rule out whether the patient is having acute ischemic stroke or not, because this is a time-sensitive emergency. We should be able to quickly identify these patients. So we should save the time, and there is a definitive timeline of the actions. And then we must have the focused investigations and the treatments. So first of all, how to recognize a stroke? Very quickly, just a brief overview. This mnemonic is a very good mnemonic we should be aware of, is a FAST screen. So FAST is, first of all, we look at the face, ask the patient to smile. If there's a drooping of the face, that means that side is paralyzed. If we ask the patient to extend the arm may be drooping. And if we ask the patient to speak, the speech will be slurred. So this mnemonic, the FAST screen, is going to detect the MC artery stroke. So it is not sufficient because it may miss the posterior fossa strokes. So for that, this mnemonic is modified to the B stroke, B fast. So B fast means it has infused the balance as well as the visual disturbances, like patient may be having diplopia or maybe having the loss of balance. So these indicates the posterior fossa stroke. So B fast is a mnemonic to quickly recognize the stroke patients. So when we recognize the patient is having stroke, we have a timeline that when the patient has reached to the emergency room, immediately within 10 minutes, he has to be attended. Within 15 minutes, a stroke team has to become in the picture. And within 25 minutes, patient should reach to the scanner. And within 45 minutes, the CT has to be interpreted. And within 60 minutes, the patient should be thrombolized. So these are the timelines when the patient reaches in the hospital. So always remember, time is brain. So in our institute, we have a stroke helpline. So the moment the patient arrives in the hospital, anesthetist is getting alert so that we will be able to reach for the patient in time for the mechanical thrombectomy if needed. So once we have recognized the patient has a stroke, we send the patient for scanner. Before that, we take the sample for the various investigations to rule out the stroke mimics. Most important stroke mimic is the hypoglycemia. So this is first investigation, which we do as in when we get a patient with the neurological deficits, followed by we take the samples for the electrolytes, SERFTs, counts, and other baseline investigation. But more importantly, we should not delay the imaging and the treatment decisions waiting for the investigations. We just take the sample and proceed with the further management. So the first thing to do is get a CT scan, non-contrast CT scan of the head done. And once we get the CT scan done, the goal is to rule out the hemorrhage complication. The patient is having ischemia or hemorrhage, that will be ruled out based on the CT scan. So we have ruled out the hemorrhage. Now the patient is having ischemic stroke. So now the next step is to quantify the ischemia. How severe is the stroke? So that if the patient is having very, very severe stroke, he may not be the candidate for thrombolysis, because if we thrombolize a patient with a large infarcted area, that may be converted in the hemorrhagic infarct. So that's why we have to quantify the stroke. So to quantify the stroke, we have the CT score, which is known as the aspect score. Here we divide the MCA territory into various regions, which are given on 1 point each. So we see the MCA territory at the two levels, one at the basal ganglion, another at the ventricle level. At basal ganglion, we have a caudate nucleus, internal capsule, and lentiform nucleus, and insular ribbon, and cortical, this frontal cortex, anterior temporal cortex, and posterior temporal cortex. So each of these cortices are given the number 1, and just immediately superior to it lies the M4, 5, and 6 areas of the MCA. So all these points in together is a total number of 10. So if the score is more than 7, that means the patient is having the poor prognosis. So how do we give the number? It is depending upon the hypodensities. These hypodensities shows the areas of the infarction. So here in this case, we can see number 1 point here, 2, 3, 1 for the insular, 4, 5, 6, and 7. So this patient is having the score total aspect score of 7. So he may be a poor prognostic factor. This score is modified for the posterior fossa scores. Here we give the marks to, here is again the number is 10. 1 mark for the thalamus, occipital lobe, and the cerebellum, and 2 marks for the, we give to the midbrain and the pons. So total score is again 10, and more than 7 again indicates the poor prognostic factor. So this is the CT-based patient severity score. So now we have the clinical scoring. Once we have diagnosed on CT the patient is having a stroke, then we should quantify the score based on the clinical presentation. This is a very, very subjective or objective scale, and it has to be done by a certified person because the patient prognosis, his improvement with the treatment and intervention is all based on this scoring system. So we give this NHSS score initially to the patient, then we follow up with this score in the post-op at 24 hours or at 3 months, at 1 month in the regular follow-up. So this score has to be done very, very carefully. It includes the dimensions like consciousness, orientations, motor and the visual functions, and the sensory symptoms as well as the articulation. So it includes all the dimensions of the intracranial functions. So a minimum score is 0 and the maximum score is 42. So based on this, we categorize the score from the minor to severe stroke. So now coming on to the management of acute ischemic stroke. So first of all, after identifying and saving the time and getting all the investigations, we have the treatment options. So what is the treatment for the stroke? As there is obstruction in the artery, the important treatment is to recanalize this artery. We have to lyse this thrombus, either by thrombolysis using the pharmacological management, or endovascular therapies like mechanical thrombectomy and medical management later on to prevent the further progress of the stroke. So just a brief overview about the thrombolytic therapy. Patients who arrive to us within less than 4.5 hours, they will receive thrombolytic therapy. If they arrive within less than 6 hours, but more than 4.5, they are candidate only for the EVT. But otherwise, if the patient arrives to us within 4.5 hours and having the proximal large vessel occlusion, then they are the candidate for the combination of therapy IV plus mechanical thrombectomy. And when the patient comes to us with a wake-up stroke, and when we don't know what was the onset of the stroke, so that means we don't know how much time is lapsed between the onset of the symptoms and the presentation to us. So we cannot be aware of if the patient lies in the time window of 6 hours or not. For that, we need further investigations like CT angio, CT perfusion, DSA, and diffusion weighted images. And we see the infarct core size and the penumbra size. If patient's clinical symptoms and the imaging mismatches there, that means they can be benefited with the mechanical thrombectomy up to 24 hours. So a few words about the thrombolytic therapy. We use the tissue plasminogen activator. How it acts? Tissue plasminogen, it activates the plasminogen to the plasmin, which lies the fibrin to the fibrin degradation product, and it will dissolve the clot. So we have the commercially available form in the form of the recombinant tissue plasminogen activator, which is alteplase. So we give in the doses of 0.9 mg per kg, but sometimes Asian population may be at risk of hemorrhage. So low dose alteplase is also recommended, especially in the Japan, they are using 0.6 mg per kg. And we have a newer next generation thrombolytic agents like retiplase, tenecteplase, which is more fibrin specific. So they do not cause much systemic damage to the body. And in the low doses, they can be used safely. A few words about the endovascular thrombectomy. This is also known as a mechanical thrombectomy. So as the name suggests, a mechanical thrombectomy means we introduce some device in the vessel, we capture the clot and take it out. So this is called as a mechanical thrombectomy. This is the area where the anesthetist has a prime role. So here, mostly it is done in the large vessel occlusion because the distal vessel and the smaller vessel, they are not amenable for the manipulations because they are so fragile. If we introduce something, there are the chances of the vessel perforation and the hemorrhage. So mainly it is done for the large vessel occlusion. And usually timeline is 6 hours, maybe extended to 24 hours. The device has to be very rapid, efficacious, and safe. So these are the various devices. This and mechanical thrombectomy has a very advanced devices nowadays. This was the penumbra device, which is a suction device. It was a primitive device where there was a cup at the end which used to suction the clot, and sometimes this clot may fragment and may migrate to the distal vessels. Nowadays, we have the enveloping coil type of the devices where the coil is passed beyond the thrombus, then it will engulf the thrombus and then it has to be removed as such entirely. And then we have the newer snare-like devices, maybe mercy retrieval and other third generation devices which have the different formation depending on their manufacturers. So after that, we have opened up the vessels. Then we have a concern that the patient should not have recurrent stroke and then patient has to be optimized. So we go for the medical management. The care of ABC, that means airway, breathing, and circulation, is the prime important thing. It has to be started when patient reaches to the emergency room, and it has to be continued throughout the care of the stroke patient. And more importantly, blood pressure management, where the anesthetist plays an important role. Whenever we receive a patient with acute intracranial insult, we all know there is an acute surge of blood pressure most of the times. So a patient may be having hypertension. So as we have learned that when the patient is having acute hemorrhagic stroke, there has to be a rapid lowering of the blood pressure to prevent the expansion of the hematoma. The same condition cannot be applied to the patient who is having acute ischemic stroke. Reason being, if we lower down the pressure, it may compromise the perfusion of the brain because the rise in the blood pressure may be a protective reflex of our body. So we should not be decreasing the blood pressure, but there should always be a limit because high blood pressure will exert a pressure on the heart and patient may develop the acute ischemia in the myocardium. So what should be the limit? Where should we act? So when the patient is not a candidate for mechanical thrombectomy or for the thrombolysis, then we can tolerate the blood pressure up to 220 by 120. But the reason we have to lower down the pressure if it is exceeding this limit. We have to target nearly 10 to 15% of reduction of the blood pressure, and we have to mind that it should never decrease beyond 25% of the baseline. And if the patient is a candidate for the thrombolytic therapy, then there's a target limit of 185 over 110. If the pressure is more than this and we give thrombolysis, then there are the chances that the patient can have intracranial hemorrhage, both for the IV thrombolysis as well as for the mechanical thrombectomy. So we have to decrease the pressure in this situation. The another important factor is the glucose. We all are aware of. Both hypoglycemia and hyperglycemia can be deleterious for the brain, and this patient invariably they do have a type 2 diabetes mellitus. So blood pressure should be controlled, and strict control should not be done because hypoglycemia has to be prevented. The target should be less than 200, preferably 140 to 180 is the recommended dose. Antipyretic has to be given because the hyperthermia is deleterious for the brain who is ischemic, because increase in the metabolism with the rise in temperature may deteriorate the brain, may compromise the further supply of the brain. Then this patient may receive aspirin. If the patient is having hemorrhagic stroke, ischemic stroke, which is secondary to cardiogenic in origin. So this patient may get the aspirin and clopidogrel if some intervention is done like mechanical thrombectomy, and statins are given for the plaque stabilization if carotid origin is there. And the statins are also anti-inflammatory and antioxidants, so they are quite beneficial for these patients. And anticoagulants are to be given in the patient who are having atrial fibrillation with the myocardial thrombosis. So cardiogenic stroke patients may receive anticoagulants. So these are the therapies which these patients may receive. So now coming on to the anesthetic management of these patients, first of all, we'll see how we manage the patient of acute ischemic stroke. So In the acute ischemic stroke scenario, always remember time is brain. Don't waste too much time in getting more investigation in these patients, because we have to do rapidly revascularization of the vessel. So quick history and examination should be done. Like we have to ask for the NPO status, quick history for any comorbidities, what medications the patient was taking, and how well controlled are the comorbidities based on those medications. If the patient has taken any medication in the morning or not, and if the patient had received any treatment or medication after arriving to the hospital, that much detail is must. Then more importantly, cardiopulmonary reserve has to be checked, especially in the patient who are having cardiogenic emboli. If the patient is having AF, they have direct implication, because if we give our anesthetic agent without looking at the cardiac status, the patient may have developed severe life-threatening arrhythmias and arrest. So cardiopulmonary reserve has to be evaluated in all the patients. Baseline investigations, what we have said before, should be checked. We have to look for the counts and all basic investigation what we need: coagulation profile, platelet counts. And now after examining, checking all the investigations and seeing whether the patient is optimized or not, we have to continue the resuscitation here in the operating room, in the intervention room, because we cannot waste the time, so much time to optimize the patient. That patient will end up with a permanent infarct. Now, once we start giving the anesthesia for these patients, we have a dilemma whether to give urgent anesthesia or we should do the case under conscious sedation. So this is a very important topic, because being a resident, when we were doing the cases, the radiologists were like, never give GA, don't give any drug, because the patient will have poor outcome. And we were surprised why the patient will have poor outcome. So because each and every technique has their own advantages and disadvantages. So in the GA, patient's airway is secured, and there are lesser chances of aspiration. And if there is any complication intraoperative like hemorrhage, seizures, that can be managed very well when the patient is having GA. And more importantly, patient is completely immobile, and there are lesser chances of vessel perforation when the patient doesn't move. But what is the advantage? Basically, when we give anesthesia, there is the induction and recovery that causes the hemodynamic stresses, leading to tachycardia, hypertension, and maybe arrhythmias. And it may be, anesthetic agent may have an effect on the autoregulatory capacity of the brain. And more importantly, there is no neurological assessment live in these patients. When we give GA, we cannot assess intraoperatively whether the patient is benefited with the recanalization or if the clot has fragmented and moved forward. So we cannot see if the patient has developed a new onset of stroke or not. So that is the major advantage of the conscious sedation. If there is any complication, we can pick up faster. We can see the recovery or worsening of the symptoms because of the migration or embolization and expansion of the hematoma. And we can, but there is a lower risk of a complication because we can pick up faster. But the major disadvantage is patient may move and there may be a catheter perforation. And more importantly, if the patient keep on moving, then interpretation of the imaging is difficult. So, and sometimes patient may become agitated, over-sedated, and there may be discomfort and tachycardia, hypotension, hypoxemia, and hypercapnia. These all things can happen. We cannot control the CO2. So these are the problem of conscious sedation. Now, again, after discussing so much, we are still in the dilemma, which technique is superior now? So because previously, people were not in the favor of general anesthesia. The reason being, most of the editorials, retrospective studies or observational studies were available till 2010. And all of them, including one of the major trial, like solitary stents trial, it states that the clinical outcome and survival rate was significantly better in the patients who underwent procedure under LA rather than under GA. So under GA, they had the poor outcome. So on this background, everybody was arguing that don't give any drug to the patient when patient is on table, even if the patient is moving so much. So we are again in the problem. So later on, there was a need of randomized control trial. So till then, they gave an excuse that the patient who underwent the procedure under GA in the retrospective studies or in the observational studies, there was a selection bias. All those patients had a very high NHSS and they were bound to have the poor outcome. And more importantly, these patients may be deteriorating because of the major hemodynamic instability, because of the anesthetic agents, delay in starting the treatment, because sometimes the help of anesthesiologist is not readily available, there may be delay in giving general anesthesia there. So, and another important is there is added risk factor of intubation and residual neuromuscular paralysis. So these are the problems what were speculated. Along with that, the one speculation which was not even proved, like neurotoxicity of anesthetic agent, that speculation was given for those who were saying that the general anesthesia is not good. But that concept was changed when randomized control trials came in picture. The major multicentric trials like Siesta and Stroke and Goliath. These are the major multicentric randomized control trials. And what they have proven that if we compare conscious sedation and general anesthesia for early neurological outcome, that NHSS score at 24 hours, it was comparable in both the groups. Not only that, even 3 months outcome was also comparable, and infarct size was also comparable in both general anesthesia and conscious sedation. So where do we lie now? That we can choose any of the anesthetic agent depending on the patient's condition. We have to keep the patient safe. If the patient is not cooperative, he's agitated, then we should go for the GA if needed. But whatever we give, we have to keep in mind the goals of anesthesia. What are the goals of anesthesia? If we maintain those goals, we cannot harm the patient, we cannot aggravate the injuries. So the goal is to prevent the secondary brain insult. That can be prevented by keeping in mind various aspects. Preventing hypoxia is must, because we know when the patient is already having ischemia and the hypoxia supersedes it, then it will kill the neurons faster. Both ischemia and hypoxemia will aggravate the injury, and it is multiplied. Another important factor is the hyper or hypocapnia. Both are deleterious. How these are deleterious? First, talk about hypercapnia. When CO2 is high, what is going to do? It will dilate the intracranial vessels. Whenever there is a ischemia, in response to ischemia, to maintain the supply, the body's mechanism is to dilate the vessels because of the local anaerobic products. They will dilate the vessels in that area. So these vessels are already dilated. So whenever there is a hypercapnia, it will dilate the vessels in the normal brain parenchyma. So what will happen? There will be a steal phenomena. Blood flow is diverted to the normal brain from the ischemic. This is called as a steal phenomena. So if hypercapnia is there, then there is ischemia of the penumbra zone. So, and what happens if we hyperventilate this patient and create a hypocapnia? If there is a hypocapnia, there will be constriction of the major vessels, and the vessel which supplies the ischemic area is also constricted. So that will decrease the supply of this area, and it will cause ischemia of the zone. So the rule is to maintain a normocapnia. The CO2 has to be maintained in the normal limit, followed by both hyper and hypotension can be deleterious. Hypertension lead to the hemorrhagic complication, hypotension lead to the ischemic complications. And another important factor is hyperthermia. As I have already discussed in the previous slide, we know brain metabolism is directly proportional to the temperature. More is the temperature, higher is the metabolism. So when the metabolism is high and supply is low, the brain will get more and more ischemia. So what we have to do is we have to treat hyperthermia very aggressively. And if we go by theory and we start decreasing the temperature and create hypothermia, it should be neuroprotective. People have this concept and they did various trials on hypothermia, but it failed to improve the outcome in the patient who had focal neurological deficits. Hypothermia has been proven to be of some important role in the patient who had a diffuse ischemia, like the patient who are recovering from the cardiac arrest, or the patient who are having the birth asphyxia. So these are the two conditions where hypothermia may play a role, but not in the focal neurological deficit. So in a nutshell, we have to maintain normothermia in these patients. Both hyper and hypoglycemia, I have already discussed, they should be avoided. Hyponatremia can also aggravate the cerebral edema, so it has to be avoided. So these are the intraoperative goals of management in these patients. So whenever we are conducting these mechanical thrombectomies, there are many complications which can happen, even if the patient is conscious or not. So if the patient is conscious, there can be airway compromise or respiratory compromise because of the oversedation, because of the aggravation of the stroke. There can be circulatory fluctuations because of the drugs or because of the hemorrhage. There can be hemorrhagic complication because of the vessel perforation, ischemic complication because of the clot migration. The thrombus may break and migrate further, or it may progress within the vessel at the local site and failure to recanalize. Then there can be local site problems at the puncture site. There can be excessive bleeding. There can be pseudoaneurysm formation. There can be thrombus formation. Then it can cause a limb ischemia, or there can be anaphylaxis secondary to the drugs or contrast which is being used. So these are the potential complications what we have to look for when we are going to for the anesthesia in these patients. Now coming to the next topic, which is the chronic stroke revascularization. So first of all, why do we need a chronic stroke revascularization? What does it mean, chronic stroke revascularization? When we have treated the acute stroke, in these patients, if there is a major vessel disease of the neck, like most of the times it can be cardiac in origin, or it can be originated from the carotid artery. There may be a plaque in the carotid which has dislodged from this place and might have migrated upward, causing the stroke. So once the patient recovers from the acute stroke, then we have to prevent the patient from the subsequent strokes. So that is called as a chronic stroke revascularization surgery. So it is of two types. It can be done with a stent placement in the carotid, or it can be done by the surgical excision of the thrombus from the carotid. So let us see one by one. So carotid artery stenting versus thrombectomy. Now, which technique is important? So a few patients may choose stenting, and in few patients they may undergo endarterectomy. Now the question is, which technique is superior? Should we choose the stenting or endarterectomy? Again, there's a mixed literature. Earlier, when the interventionists were not experienced, then the outcome of stenting were bad. But currently, because of the large experience and advanced technology of the intervention and big trials like Sapphire and SPACE study and the CREST trial, they have suggested that there's no difference in the neurological outcome, stroke or MI. And after 30 days, ipsilateral stroke and restenosis rate were also comparable amongst these two techniques. So these two choice of the technique will depend upon the patient's condition. Sometimes patient will be so moribund that they may not be a candidate for the surgical excision, then stenting may be done in those conditions. So how do we choose the patient for the chronic stroke revascularization? Patient who is symptomatic and having severe stenosis should have a perioperative risk of death and stroke less than 6%. And asymptomatic patients who are having severe stenosis should have a perioperative risk of stroke and death of less than 3%. These are the candidates which are chosen for the revascularization surgery. Now, what is this risk? How do we define 6% or 3% risk? So that will be done in the PAC. So we have to do the risk stratification first, and then we do the optimization of the pre-existing medical conditions. We have to see the indication for the occult cardiac condition. What is this term, occult cardiac condition? Sometimes the patient who is coming with a stroke and having the major vascular disease of the extracranial carotid. In those conditions, approximately 60 to 70% of these patients, they have underlying CAD. So how do we know that the patient is having CAD? Even if they are not presenting the symptoms, we have to definitely go for the screening, go for ECG and stress testing. And stress testing is definitely indicated to rule out the occult cardiac condition. As this chronic stroke prevention is not an emergent condition, we are doing it for the prophylaxis to prevent the further stroke. So we have a time to evaluate the patient. Here, the patient evaluation and optimization is a prime important thing. Now, we have to do the, if the stress testing is positive, then we can go for the angiography and the coronary revascularization if needed. Then we have to formulate our plan, whether to proceed with the GA or conscious sedation. And then we do the complete neurological exam and document it. And we have to go for the chart and angio review to see if the patient is high risk or not. If the patient is having high-grade contralateral carotid disease, the patient and poor collateral, they may be high-risk candidate for deep hyperperfusion syndrome, which I'll be dealing in the subsequent slides. So coming on to the risk stratification, we look at 3 parameters: medical conditions of the patient with a major organ involvement, obesity, and advanced age; neurological risk with the progressive strokes; and angiographic risk with the severe stenosis in the contralateral vessels, and the high carotid bifurcation stroke. So these are the risk potential parameters which define the risk of the patient. And depending on these factors, if the patient is having high risk for the neurological, that means the patient is having unstable neurological status, they have progressive or the recurrent strokes, and patient is having severe myocardial or the pulmonary condition, and the patient is having very high severe stenosis in the contralateral and ipsilateral vessels. So these patients has a very high risk for the perioperative morbidity and mortality. Then next, coming on to the procedure as such, for carotid stenting procedure, first of all, we do the ensure there is a stenosis here where the stent is to be placed. First of all, a guiding catheter is placed in the common carotid artery. Then a protection device, this is like umbrella-like protection device, is placed crossing the plaque. So it has to be distal to the obstruction, so that when during the procedure, there can be rupture of this plaque and it can migrate upwards. So to protect that, this is called as a protection device. Then we can do the balloon angioplasty, or sometimes it may be sufficient to do only balloon angioplasty, or sometimes we do the pre-dilatation. This is called as a before placing the stent, we just dilate the carotid with the balloon. So this is pre-dilatation. Followed by this, we deploy the stent and then we inflate the balloon again. This is a larger balloon to open up the stent. So this is how stenting is done. It looks like a very simple procedure, but there can be the major hemodynamic instability during this procedure. The reason being, the carotid sinus pressure changes. The carotid sinus is actually adapted to the low pressure whenever there is occlusion. And suddenly when we release that occlusion, it will sense the pressure is very high, and it will send the signal to the brain, and which is going to activate the parasympathetic system, will cause the bradycardia and hypotension, and may even asystole. So in this patient, so we have to be ready to manage those conditions. We have to be ready for the percutaneous or temporary pacing in these cases. Other preoperative medications these patients may be receiving are dual antiplatelets sometimes, because they are required to prevent the stent thrombosis, and dual antiplatelets are usually started 1 or 2 weeks prior to the procedure. Statins are started preoperatively. And beta blockers, there is a controversy of the beta blockers. If we start it within 24 hours prior to the procedure or prior to the surgery, it may increase the risk of perioperative strokes because of the hypotension and MI. So immediately before surgery, we should not be starting the beta blockers. But if the patient is taking beta blockers for the long term, we have to continue. And if you want to start the beta blockers to protect the myocardium, then it has to be initiated around 2 to 7 days prior to the procedure. So now coming on to the anesthetic management of stenting. So most of the time, stenting is being done under the local anesthesia. Routine monitoring is advised along with the lead 3 to 5 monitoring for the ischemia of the myocardium, because this patient may have very high risk of coronary artery disease. Invasive blood pressure should be monitored because of the major hemodynamic instability is expected. Other invasive lines like CVP or urinary catheter may not be required in these procedures. Now coming on to the surgical technique of carotid end arterectomy. So this is a surgical technique where we give the incision on the anterior border of the sternocleidomastoid, then we expose the vessel, incise it. After clamping common carotid, external and internal carotid arteries. And then we remove the plaque surgically and then suture it. So now here, what should be the anesthesia? As it cannot be done just like we do the stenting in an awake patient. Patient needs some kind of anesthesia. We can give the regional blocks like superficial deep cervical blocks and epidural block, or we can give the general anesthesia. Now again, whenever we have the two techniques, we still develop the dilemma which technique is to be chosen. So just a brief about superficial block. It is given subcutaneous infiltration of local anesthetic at the posterior border of the sternocleidomastoid muscles, and the deep cervical block is given by drawing a line from the mastoid to the C6 tubercle, and then 2 centimeter, 4 centimeter, and 6 centimeter away from it. These are the C2, C3, and C4 tubercles. So we give local anesthesia near 3 to 5 ml at each point. So deep cervical plexus block is actually associated with the various severe complications. So most of the users, they opt for the superficial cervical blocks, which is sufficient, which provides a sufficient anesthesia for this procedure. So now, as I was talking about the dilemma of choosing whether we should choose GA or LA, the problems are same. We have the better control on hemodynamics, but the neurological assessment is not there. And in conscious sedation, yes, when in the carotid artery, they are placing the clamp in the common carotid. That means that side of hemisphere is not getting any perfusion. So if we do not monitor anything, then patient may get up with a severe stroke on that side because of the hypoperfusion. So we should have some monitor. If the patient is awake and we are clamping the artery, so we know the collaterals are good if the patient is not developing any deficit. But if patient starts developing deficits, that means collaterals are not good, and patient will develop the huge ischemia of the brain. So that way, local anesthesia takes some precedence. So the choice of anesthesia is still a dilemma, but various studies, like again, various multicentric trials have stated that there is no difference in the outcome when we choose the general anesthesia or the local anesthesia as far as stroke, MI, or the death is concerned. So anyone who is like experienced in local anesthesia can give regional blocks or epidurals, or if the person is perfect in giving GA and monitoring the patient with other tools which can monitor the cerebral physiology, then they can go safely for the GA. So now the goals of general anesthesia, again, which we have to maintain, we have to protect the brain. The major goal here is when we put a cross-aortic cross-clamping, carotid cross-clamping, then the brain has to be protected. How do we protect the brain? We have to improve the perfusion of that area of the brain by either by increasing the cross flow, by increasing the blood pressure, or by using the stent, which I will be dealing in the subsequent slides. Along with that, we have to maintain the hemodynamic stability, because when we are applying a cross clamp on the carotid, there will be reduced supply of the baroreceptors, and they will sense hypoperfusion, and then it will again initiate a cycle that will increase the blood pressure. So we have to maintain that hemodynamic stability, and we have to ablate the stress responses because of the surgery, and at the end, patient has to be awake for the neurological assessment. So this is what I was talking about. If they stretch the carotid sinus, these are the various complications which can occur, like hypotension, bradycardia occurs because of the manipulation of the carotid sinus. And after cross clamping, there is a reduced perfusion that will give stimulus to the brain, and it will increase the blood pressure. So usually 20% rise in blood pressure is acceptable. If the blood pressure is rising beyond that, that means the brain is getting lesser perfusion. So the patient may develop the ischemia. So that is a condition which is alarming, and it may strain the heart and may cause MI also. So how do we protect the brain when we are detecting that there's a reduced perfusion in the brain? We have to again go for the rule of 6H that we have discussed before: normocapnia, normoglycemia. Now, cerebral protection with the anesthetic agent has been discussed a lot. So we can give the additional boluses of the local general anesthetics, increase the depth of anesthesia. But these old drugs has not been proven to improve the neurological outcomes in these cases. So what we can do is we can give the hypertension that has shown to improve the collateral flow, and we have to give 100% oxygen when the brain is not getting much perfusion. And even despite hypertension, if the contralateral brain is not getting the perfusion, then we have to do the carotid shunt placement. So what is the carotid shunt placement? We bypass the surgical area, which is clamped. So we put a stent in the proximal vessel, and above the clamp, we put the shunt. So we are bypassing this clamp area and maintaining the perfusion of the ipsilateral brain. But the problem here of this shunt is it can suck the air inside from the surgical field. It can suck the emboli also from here. The debris from the surgical side can also go. So the patient is having very high chances of embolic strokes. So the important one of the important aspects is if the surgeon is not experienced with the shunt placement, it can make the surgical technique also difficult. So it is also the matter of experience of the surgeon. So regarding neurological monitoring, which is very, very important when we are doing this carotid endarterectomies, We have to identify intraoperative emboli complications, whatever is happening, because we are dissecting the area and emboli can go inside the brain. So we have to monitor that, and we have to see if there is a tolerance to the cross clamping when shunt is not placed, or we have to see if there is a need of shunt placement. So we should have some monitors, like most important monitor is a stump pressure monitor. So what is the stump pressure? When we clamp this common carotid and external carotid, then we put a needle and measure the pressure over here. This is called as a stump pressure. So a 25 mm stump pressure is acceptable. So whenever there is a high stump pressure, that is good if the patient is getting good perfusion from the controlator side. This is this is a patient. This is Kifled, and after clamping, this is the needle which is inserted in the carotid to see the pressure on the monitor. So after this, we should have a TCD monitor also. If we have a combination of two monitors like stump pressure along with the TCD, NIRS, or any other neurophysiological monitoring, then it can give protection to the brain. So what TCD is showing here is when the clamp was applied on the common carotid artery, there was a decrease in the flow on the ipsilateral right ACA. But after some time, there was increase in the flow of the left ACA. That means when we increase the blood pressure, left ACA flow increased to perfuse the blood on the right side. So this is compensatory mechanism. So with these tools, we can know if our interventions are working or not working. Despite increasing the blood pressure, if there is no increase in the contralateral flow, that means our intervention is not working and the collaterals are poor. And along with that, we have another monitor like EEG or NIRS, which we can use in these patients intraoperatively. So once the surgery is done successfully, patient should be rapidly awakened without straining the patient. We have to take care of all the cardiac responses. In the post-operative period, oxygen supplementation, IV fluid, and monitoring, these things are important, but we generally do all these things in all the patients. What is important here is to monitor TCT. Why do we monitor this? To detect the post-operative complications like hyperperfusion syndrome, or there may be hemodynamic fluctuation secondary to the baroreceptor dysfunction. There can be stroke, MI, death, or neuronal injury in the adjacent structures like hypoglossal facial nerve injury. There can be a local wound hematoma. So a brief about the hyperperfusion syndrome. It is a clinical triad of the ipsilateral headache, especially hemifacial headache, seizures, and focal neurological deficits. It that arise in the absence of the cerebral ischemia. This is very, very important. If it arises because of the cerebral ischemia, it is called stroke. If it happens without the cerebral ischemia, then it is the hyperperfusion syndrome in the post-operative periods. So how do it happen? This is just remember the normal physiology. Whenever there is a obstruction, then the segment beyond the obstruction will dilate to compensate for the reduced perfusion, to increase the perfusion a bit. And this will dilate in the chronic cases. And once this dilatation is suddenly taken care of, there is a huge flow which is going inside the vessel, because this dilated vessel will take some time to go back to the normal caliber. And so for some time, it may not have that reactivity to the pressure changes. So this dilated vessel flow will increase immediately once the obstruction is relieved. And this flow may increase up to 200 times. So that it can cause the hyperperfusion syndrome. And how the patient is going to present is, because of the sudden gush of blood, they can have microhemorrhages, hematoma formations. They may present with the seizures and cerebral edema. So it can be diagnosed with the TCD because of the rise of the velocity of more than 200. And we may go for the CT scan and MRI depending on the patient condition. Now coming on to the last topic, stroke patient for other surgeries. Whenever a patient comes to us, now the most important topic question is, when should we get these patients operated after stroke? So the rule is, we know that after stroke, the brain is not as normal as a normal person. So they may be having some problems there. Most important problem is the problem with the autoregulation. So their physiology is deranged, and that derangement may persist for months. So this is a major study which was published in JAMA, which has shown that the 30 days MACE, that is major acute cerebrovascular events, and the mortality and ischemic stroke rates were actually higher within 9 months of the stroke So we have to delay totally elective surgery up to 9 months of the acute ischemic stroke and up to 4 to 6 weeks after the CEA. So same way, we have to assess this patient thoroughly. If the patient is coming for the elective surgery, we have to look for all the comorbidities that the patient can have and look, optimize these. In emergency situation, we do not go for the complete optimization. We may do a co-resuscitation and take up this patient for the emergency surgeries. But routinely, we have to take care of all the comorbidities. Along with that, various medication what the patient may be receiving. So just have a look on those things. Most importantly is physiological derangements in these patients. The patient who had a stroke previously, they are having disabilities now. Sometimes they may be chronically disabled. So they may be very weak. They may be having residual neurological paralysis. There is a loss of autoregulation on mostly on the bilateral side of the hemisphere. And there may be impaired vasomotor reactivity, especially in the patient who has undergone CEA up to 3 months. So what are the perioperative concerns? The major perioperative concern when a post-stroke patient comes to us is recurrence of the stroke. So this is the major complication which can happen in the post-op. How do we see it? The stroke can recur because of the hemodynamic instabilities. When the patient develops a major hypotension, then they are prone for the stroke. And more importantly, stopping the medication. Patient may be on dual antiplatelets, maybe on anticoagulants. We have to stop those drugs preoperatively, and that makes this patient prone for the stroke. And more importantly, the patient who is debilitated may be immobile. And in certain surgeries, there is a prolonged immobility, and that may be the source of the stroke again. So this is the major concern. Another concern is the re-emergence of the neurological deficit. That means a patient who is fully recovered of the stroke may develop the stroke symptoms in the post-op without ischemia. So that is called as a rewiring effect. That means there is no ischemia, but the patient's inserted brain, it behaves differently to the anesthetic agents. They may have a high sensitivity to the GABA inhibition, and that's why they recover very, very slowly. And sometimes that part of the brain function very less, and they may have reoccurrence of the symptoms in the absence of ischemia. Another important is anesthesia concern related to the prior stroke because of the debility, and the patient may be having increased risk of aspiration because of loss of reflexes in the patient with the posterior fossa stroke. They may be having weak gag or cough. Sometimes because of the paralysis, they may be having DVT, or because of the poor nutritional intake, they may be having hypoalbuminemia, dyselectrolytemia. That has to be taken care of if they are coming for the elective surgeries. And problem related to the concomitant disease may persist. Then preoperative optimization is very, very important. The most important thing is, even if the patient's motor function recovers, there may be subtle changes in the memory and emotional liabilities or inability to express. These are the subtle signs which may indicate patient may be having stroke symptoms even today. They may not be completely normal. So they have to undergo a thorough neurological examination along with the cardiovascular status studies may be indicated if we find such changes. Otherwise, routinely these imagings like TCD, MRI or MR angios are routinely not required. But if they present with some symptoms, we should undergo some imaging. And more importantly, we have to take the consent for the perioperative stroke and neurological deterioration in these patients. And then look for any comorbidities, disabilities, and try to optimize as much as we can and assess the severity of the surgical illness. Sometimes the surgical disease is very severe and we have to proceed without complete optimization. I was talking about the concurrent medication where the patient may be on. As with the previous knowledge, we know this patient may be on antihypertensive for control of blood pressure. They will be on statins and the beta blockers and antiplatelets. Like they may be on single or dual antiplatelets. If the patient is receiving low dose ecosprin, that may be continued for the surgeries, which are low risk for the bleeding. But clopidogrel has to be stopped 5 to 7 days before. And even if the patient is posted for the high risk for bleeding surgeries, then both the antiplatelets has to be stopped. And regarding anticoagulants, we should stop the anticoagulants and we can start the bridging therapy in these patients. So the important thing is we can continue these 3 medication, antihypertensive, statins, and the beta blockers, but we may have to rethink about the antiplatelets and anticoagulants. So what we can do is a bridging therapy. We can stop anticoagulants and antiplatelet and go for low molecular weight heparin or unfractionated heparin. There may be, we have glycoprotein 2B and 3A inhibitors like etifibatide and the tirofiban, which having the rapid offset. And more importantly, the newer drug, which is canglirol, it has the offset of 1 hour. So we just stop the infusion of this drug. These are the intravenous drugs. So we give these drugs in the infusion, and we can stop nearly 4 to 8 hours before the surgery, and then we can proceed with the surgery. So major anesthetic concerns are minimal or no sedation, as the patient who had a stroke can have a rewiring or rewinding effect because of the benzodiazepines. It is well known when the patient is receiving benzodiazepines, they are sensitive for the GABA inhibition, and they may present with a stroke type of symptoms. So anti-aspiration prophylaxis is important when the patient is having poor gag and cough and the delayed gastric emptying because of the paralysis. Another important factor is the goals of anesthesia. We have to maintain secondary brain damage has to be avoided, and we all are aware of how to prevent the secondary brain damage. Then standard ASA monitoring and invasive monitoring, depending upon the surgeries we have to use. Important point about the NMT should be used on the non-affected side. And another important thing is TCD and NIRS, advanced physiological monitoring, may be used in the patient who are high risk for the intraoperative hemodynamics instability. So now important thing is what to choose in this patient. Again, we have a dilemma between the general anesthesia and regional anesthesia. A post-stroke patient comes to you for the limb surgery. What will you choose, whether to choose for the general anesthesia or regional? So here I can't be so sure, because these are the few articles which were taken from the orthopedic trauma. So or TKR, THR studies, and they have shown the GA patient had a high risk of stroke. This cannot be extrapolated to the general population because these patients were entirely different. So I would say the evidence is lacking. It has to be individualized. We have to weigh the risk and benefit of the patient. Definitely in the regional anesthesia, hemodynamic instabilities are lesser, so they will affect the cerebral physiology to a lesser extent. But still, major studies are required to prove that. So regarding anesthesia drugs, we still have insufficient data to favor one agent over another. We cannot favor inhalation over the IV. We do not have enough evidence. But yes, ceftriaxone should be avoided after the major strokes, and the patient blood pressure should be maintained within 10% of the baseline, and we have to avoid the deliberate hypotension or hypertension in these patients. And if the surgery is in upright position, transducer should be kept at the level of the skull so that we can monitor the cerebral perfusion pressure. And we have to avoid hyperventilation and hypoventilation both. And anemia should be aggressively treated in these patients because we have to maintain the oxygen carrying capacity. Regarding the emergence from the stroke, there may be a differential awakening. What is this differential awakening? When the patient develops the stroke type of symptom in the post-op, when that's up and he's not moving one half of the body, and slowly it starts recovering within next 15-20 minutes or maybe 1 or 2 hours. So we cannot predict how these patients will behave in the post-op. Sometimes patient who is apparently healthy, having full power, may get up with the weakness on one side, which is slowly recovering. This is called as a differential awakening, and one half of the body is getting up very late, recovering very late from the neuromuscular relaxants. So this is called as a differential awakening. And once the patient is awake fully, we have to do a thorough neurological examination. If the patient has a new deficit, immediately they have to undergo radiological evaluation in the form of CT scan or MRI, whatever is indicated. And then this patient may remain immobile, so DVT prophylaxis is must. And we have to start the long-term medication as soon as possible after the stroke, after the surgery. So to summarize my talk, time is brain. We have to always preserve the brain, act fast. We have to do a rapid and quick evaluation in this acute scenarios, and a thorough evaluation and optimization is must in the chronic strokes. And we have to maintain the supply and demand to protect the brain, which is very, very important in the post-stroke patients, and delay elective surgeries as much as possible, at least for 6 to 8 months. So thank you very much for the patient hearing.
Thank you, Dr. Kiran. It was an elaborate and very extensive presentation. I know this topic, we can talk for hours and days on whatever you have dealt in last 1 hour. And it was a very well presented topic. And with the permission of Dr. Sandeep Sahu, I think we can open the session for discussion.
Yes, sir. We have write in the chat box that we inviting questions. Definitely, the topic has been covered, I will say, both for acute and chronic stroke. And as the days now at 40, the patients are having more diabetes and hypertension, even in doctors. And you find that suddenly one day, one find that, oh, somebody is unconscious, and at young age we are finding stroke, and these patients are coming for acute care or for post-stroke patients for other surgeries. And if we don't understand the pathophysiology and the changes occurring in the old brain areas, either they infarct or bleed, the patient can be complicated. You have undergone a patient lap chole and suddenly patient is not awakening. And this also we have seen also here in few cases. And once we keep remember this talk that is nicely covered by Dr. Kiran, we can give benefit to the patients. So before shifting to the questions from this session, we have questions from the last session. So the first question that we are discussing, how is hemodynamic maintenance done in these patients, means post-transplant patient? Do they require inotrope and vasopressor as the transplant organ is devoid of autoregulation? This is by Dr. Muthukumar. Dr. Gaurav, you would like to answer, or?
Yes, sir. I would like to answer this question. Again, to make this question more specific, if this question is about the post-heart transplant patients, of course, these patients, they are in, their neurons have gone away. So for these patients, but still the organ have its receptor. So it is advisable to use the directly acting vasopressor or the inotropic agent, especially in case of a heart transplant patient. Atropine is not going to act. So they have recommended to use the directly acting agents such as adrenaline and the noradrenaline for these patients. And in fact, the isoprenaline and the dobutamine, they are found to have a similar effect for both the post-transplant and the non-transplant patients. So if this question is with regard to the heart transplant, the answer is yes. We should use the ADR and the non-ADR. And with respect to the liver transplantation, yes, the choice of inotrope is going to be changed. Between NOR-ADR and ADR, NOR-ADR is going to be the preferred choice of agent because ADR is going to cause a lot of tachycardia to the patient, which can cause the congestion of the organ. And compared to the vasopressin, yes, of course, again, NOR-ADR is the preferred choice because vasopressin is going to have an impact on the portal circulation.
Yeah, you rightly said, Dr. Gaurav. Whenever the post-transplant patient is coming, our aim is avoid secondary hypoxia, hypotension that can complicate any organ. Usually this problem is not in renal patients because they mostly remain hypertensive even after the renal transplant, and the liver transplant patient, they improve a lot after the graft is functioning properly. But definitely the cardiac transplant, they patient behave differently. Anyhow, we have to manage these hypotensive patients as per the protocol that we are using perioperatively, judicious use of fluid, seeing the fluid responsiveness, and wisely use of inotrope vasopressor. At least we can have a invasive arterial line if we are finding these patients are towards hypotension, or for better management and monitoring, at least. The another question we are taking is from Dr. Ratan Gupta. He is taking how to take care of COVID ARDS in post-transplant patient.
Yes, to answer this question, yes, it is definitely a very challenging situation where these patients are on immunosuppressant, and if the patient land up in a severe COVID ARDS, actually the recommendation is for the mild and the moderate COVID ARDS. For the mild and the moderate disease, it is recommended not to change the immunosuppressive agent. But if they are going for a severe COVID ARDS, stepping down of the immunosuppressant is required for this patient. So we had one case where the patient had a severe COVID immediately after the liver transplantation, and we stepped down all the immunosuppressive agents, especially the CNIs, calcineurin inhibitors, and the antimetabolites, and we put that patient only on the steroid, and that patient responded well to the steroid because steroids are going to help in the COVID also. So that was one of the case we recently faced. So recommendation
Dr.
is
Gaurav, we have one more questions. This is how is laparoscopic surgeries in post-transplant patient in the view of organ perfusion due to pneumoperitoneum by Dr. Muthu Kumar.
Again, for the laparoscopic surgery, as such, there are no special consideration for the laparoscopic surgeries. But one very important point is the timing of the surgery at which these patients are undergoing the surgery. So if they are undergoing a surgery in the immediate post-transplant period, then definitely the maintenance of hemodynamics becomes very important for these patients, because any alteration in the hemodynamics of these patients can have a devastating effect on the recently transplanted organ, especially with case of the liver transplantation. Because after liver transplantation, as I have told in my talk also, that it is going to take at least months to years for these hemodynamics to recover after the liver transplantation. So it is very important to know what time they had a transplant, and if it is an immediate transplant period, all precautions should be taken to maintain their hemodynamics. And definitely other concerns are same as for the other post-transplant patients, such as the risk of infection, risk of organ rejection in the perioperative period.
Okay, Dr. Gaurav, this much questions for with you, and thank you so much for your presence and till last of the session. Now this question is with Dr. Kiran, or Dr. Bhagat can also give the answer. How long will we have to wait for elective surgeries like hernia or giving spinal after acute stroke? Dr. Kiran, would you like to answer?
Yes, sir. I have already explained that the autoregulation is deranged till at least 3 months post-stroke. So this is the minimum time where we have to wait. But for hernia surgery, which is purely elective surgery, if the patient is not at risk of obstruction, then we should definitely wait for 9 months at least. That much time is needed for the physiology to completely recover to normal.
Definitely in acute stroke, we are worried about herniation and all that. And besides going in debate or putting our patient towards unsafe, it is standard practice to avoid it and use general anesthesia with the regional nerve block if possible, not the central neuroaxial blockage. And another question is, do you use ketamine in neurointervention anesthesia? Dr. Pasha is asking for this question, use of ketamine in neurointervention.
So routinely practicing, we do not have experience of using ketamine in the neurointervention because the patient is having acutely deranged physiology. We are using those in the patient of acute head injury with the propofol. We are using ketofol. We do not give ketamine alone because definitely there are problems with the ketamine. It increases the CMRO2. So I don't think we are preferring ketamine for the acute ischemic stroke. So most of the important drugs we are giving is propofol. Dexmedetomidine is coming up because of some neuroprotective effects as well. So that is the fentanyl, midazolam, and propofol, and dexmedetomidine. These are the drugs which we are using in the intervention.
I would like to just supplement to what Dr. Kiran has said. First, the question was like whether to give spinal. As Dr. Kiran has already said, now if once the cerebral physiology has stabilized, that is, say, after 3 months and preferably after maybe 9 months, then the question of whether giving a GA or regional anesthesia, they are almost equivocal, because the most important is that you need to prevent all the factors which aggravate the neurological functions like hypoxia, hypotension, hyperthermia. So these factors are more important rather than the choice of anesthesia. And as far as ketamine is concerned, now, as Dr. Kiran has said, even in the literature, there is no description of use of ketamine in patients with acute ischemic stroke. But one of the factors which can affect in a patient if you are giving a conscious sedation, because they have the side effect of causing, psychosis and aggravating the agitation. So this patient can, behave very abnormally if they're using ketamine along with the conscious sedation. So there you have to exercise caution in these patients.
Definitely, sir. And I will add on one thing, that whenever you are getting post-neurological or post-stroke patient, always, because anesthetists are very busy and they don't found time to put things before taking patient the neurological examination. So it's better to demarcate the neurological examination by a neurologist, so that you have that what is the patient neurological status in terms of focal neurological deficit, the motor sensory and cranial nerve examination. This will help you also for the making medical legal issues in these patients that can come. So it is always important in PAC, at least you demarcate the neurological examination. If you are not sure or you are not confident, then take help of a neurologist. That will help us, because these patients can have the motor or sensory weakness that can be aggravated later on because of various reasons, not only by anesthesia. So I always say for safer surgery, it's not unsafe anesthesia. It is for safe surgery in these high-risk patients. We have to do this, and also the counseling and the consent. That is also important part to document the counseling and consent, that what is safe for patient to be discussed with him, the anesthesia plan, before giving anesthesia in these type of patients. So with this, we have any more questions? Anybody can ask by unmuting or just putting in the chat box. Although our speakers and our chairpersons have enlightened us enough on both the topics. So if we don't have any question, I request the ICA office bearers. Dr. Radha Krishnan sir.
From the delegate side.
Yeah. Devalina, do we have any more concern? Or
No, sir, no. That was all.
so thank you both the speakers and the chairpersons for your valuable time, your efforts that you have done for, I will say, for the weeks to prepare the topics, so that we are enlightened with the knowledge that you shared with us. I will request Radha Krishnan sir to take over and for the end of this session.
Yeah, hello.
Yeah, sir, we are listening.
Yeah, the webinar was wonderful, I must say. I have a small question to Kiran. Is there any consensus we're reaching now regarding the use of GA or RA in post-ischemic strokes? You were telling it is, even today, it's slightly evasive. Nobody has come out very clearly. But I believe the fight was going on between the transatlantic groups with the American groups and the European groups. And what I like to know is that whether in a real confirmation has come, whether GA is good or RA is good, or well, up to your imagination or on your discussion, you may use either GA or RA in an ischemic patient for any particular surgical work.
Sir, thank you, sir, for the question. And Dr. Hemant has partially answered this question already. I would like to emphasize here is like whatever limited literature is there, I could find is there in the orthopedic surgeries, where they have said the patient who underwent surgeries under GA, they have higher risk of stroke because of the major hemodynamic instabilities which we get when the patient is being operated under GA, or the patient is having high risk for DVT if we are giving GA. So there are 3-4 types of speculation they have made, and they have said that the GA may worsen the patient's neurological status if being given in the patient who had recent stroke. or post-stroke patient. But till now, there is no conclusive evidence in the literature. Literature is very sparse. So we have to choose our patient from case to case basis. We have to individualize the management. If the patient's physiology is absolutely stable, we take care of all the secondary insults, we maintain the hemodynamics, then any kind of anesthesia can be given. Definitely, regional anesthesia has an upper hand, provided patient is not on anticoagulants and antiplatelets and surgery is urgent, then we don't have any choice. But if we have a choice, then regional anesthesia or the local blocks may have a upper hand because of the lesser hemodynamic instabilities. But once the physiology is normal, it is immaterial what kind of anesthesia we are using. It is the most important thing is how we are giving. That is important.
Thank you, Kiran. Then what is the future of awake craniotomy, or do you advise awake craniotomy in these circumstances?
Sir, awake craniotomy is definitely good because when we are talking about awake versus GA, then awake patient is always a better monitor. If we have some intraoperative progression of the problem or thing which we can catch faster, so we can manipulate our intervention and we can know the consequences of those intervention faster. If we increase the blood pressure and patient is recovering, that means our intervention is working well. That advantage we do not have when we are giving GA. If the patient is a candidate for awake craniotomy, definitely that is good. So we can proceed with the awake craniotomy.
But do you think it's ethical in a conscious patient without much problem, but craniotomy to be done? But is it ethical to do it in a normal conscious patient where surgery is mandated?
Sorry, sir, I didn't get the question.
Now, what I'm wondering regarding the awake craniotomy, you were telling it is always good to do the awake craniotomy. But do you think it is ethically correct to go for awake craniotomy?
Sir, awake craniotomy has its special indication. We do not do awake craniotomy in all the patients. It is done only when the risks are lesser and the benefit is more. That means when the patient's tumor is an eloquent area and we have to protect that area. And in certain circumstances where the patient's comorbidities are so much that they may not tolerate GA. So there are special indications for awake. Routinely doing awake craniotomy is not indicated because intraoperative complications, if they occur, then it is very, very difficult to manage sometimes with the open brain. A patient may throw seizures, patient may have massive bleeding intraoperatively. So those situations that may be complex. So, but wherever indicated, we may proceed with the awake, but it should not be done routinely in all the cases.
And also I would like to chip in here, like awake airway, into awake intubation, here also the awake craniotomy is not awake. It's anesthetized with proper analgesia sedation, with coordination of surgeon. Whenever they are touching the eloquent area, then only the patient is briefly awake and again put on sleep. So this combination definitely needed like harmony, more harmony with the surgeon and very pre-planning of the procedure. That can be safely done.
So the plane of anesthesia is brought down depending on the circumstances, I believe. Yeah.
Yes, sir.
Okay, thank you. Thank you very much for a wonderful session.
So, thank you, sir.
I believe Dr. Jayashree is there. Is Dr. Jayashree anywhere available? Hello?
Sir, I think is this panel, Dr. Murli sir is there, and all the speaker and chairperson, ma'am is not. I am not able to see.
I think because she was busy in the evening, I was not able to contact her. Dr. Murli, will you give a formal vote of thanks on behalf of ICA?
Yes. It was a brilliant session today, dealing with difficult subject. Thank you very much for joining. On behalf of ICA, I would like to thank the faculty and all the speakers for having contributed to this webinar. And I would like to thank the ICA leadership, Dr. Radhakrishnan, Dr. Jayashree, Dr. Baljit Singh for continuing these webinars in a very punctual and methodical manner for the benefit of the practicing anesthesiologists and training anesthesiologists. With this, I would like to thank everybody and thank you so much. We'll meet again on Wednesday.
Thank
Next
you.
Wednesday,
Thank you, Debalina.
And thank you for the participants for their continuous
yes,
support
yes.
to be in, to help in these sessions. And thank you for the chairperson and speakers. Have a good night, and I think this is time for dinner. Bye bye. See you next in the next academic webinar. And thanks for opportunity to all of us.
Thank you so
Sandeep.
much.
Thank you. Thank you.
Thank you.
Thank you so much, all. We are closing here. Good night.
Thank you,
Debalina, we
Debalina.
can leave now.
See you next week.
Yes,
Yeah,
see you next week.
Good night.
Good night.
I'll
Bye
see you
bye.
next week.